1 and 2 and 3 and breathe in. 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 I think it's been about 30 seconds. Breathe in. I'm going to recheck.
Endotracheal intubation may be necessary when bag and mask ventilation is prolonged or ineffective to better coordinate chest compressions with ventilation or to administer epinephrine while venous access is established.
I think we're going to need to go ahead and intubate the baby.
Okay, yeah, heart rate's still about 20. 1 and 2
How
and
can
3
I help?
and
We're about ready to go ahead and intubate.
Breathe in.
Okay.
1 and 2
Do you think we
and
can
3
get
and
it?
breathe in. 1 and 2 and 3 and
laryngoscope.
1 and 2 and 3
We have a
and breathe in.
3-5
1 and 2
endotracheal
and 3
tube.
and
Okay.
breathe in. 1 and 2 and 3 and breathe in.
Okay, hold
1 and
compressions.
2
We're going to go
and
ahead
3
and
breathe in.
Stabilize the head in a slightly extended position and deliver free flow oxygen. As you insert the laryngoscope, you can see the posterior wall of the hypopharynx. Elevate the laryngoscope slightly and you can see the epiglottis and glottis come into view. However, if you insert the laryngoscope deeper, you see the opening of the esophagus. If the laryngoscope is to the left or right of the midline, you can see only part of the glottis. Insert the laryngoscope to the proper depth in the midline and the epiglottis comes into view, serving as your landmark. At that point, lift the blade of the laryngoscope upward and away so that the vocal cords come fully into view. Sometimes pressure over the larynx will help visualize the glottis. Insert the endotracheal tube through the vocal cords to the appropriate guideline. Remove the laryngoscope while holding the tube firmly against the palate.
Going to ventilate? Okay, I'm seeing good chest movement. I'm seeing good
The primary signs of correct endotracheal tube placement are increasing heart rate and color change in a CO2 detector.
And I hear nothing over the sound. Yeah.
The entire procedure ideally should take no longer than 20 seconds.
It's still low.
Okay, let's resume chest compressions.
Okay. 1 and 2 and 3 and breathe.
The laryngeal mask airway is an alternative to provide positive pressure ventilation when bag and mask ventilation is unsuccessful or intubation is not possible. First, inspect the device and test the mask by inflating it with 4 mL of air. Then remove the air completely. Position the baby's head in the sniffing position. Hold the device like a pen with your index finger at the junction of the cuff and the tube. Open the baby's mouth and press the tip of the mask upward against the palate with the index finger, making sure the mask does not curl backwards on itself. Advance the mask into the hypopharynx until resistance is felt when the opening covers the larynx. Stabilize the tube with the free hand while removing the index finger. Inflate the mask with 2 to 4 mL of air to achieve a seal. Do not hold the tube during inflation, as the device may move slightly outward. Attach the resuscitation bag and begin positive pressure ventilation to confirm placement. An end-tidal carbon dioxide detector can be used, and the laryngeal mask airway can be secured with tape or another securing device. The airway may be removed electively after deflating the balloon, or the baby may cough it out spontaneously. If the heart rate remains below 60 beats per minute, despite ventilation with 100% oxygen and coordinated chest compressions, you should administer epinephrine. You also need to assess the possibility of hypovolemia and give volume if necessary.
2 and 3 and breathe in. 1 and 2 and 3 and breathe in.
When the heart rate remains below 60 beats per minute, despite 30 seconds of assisted ventilation, followed by another 30 seconds of coordinated chest compressions and ventilations, epinephrine should be given by umbilical vein.
Okay, Dr. Lee, I think we're going to need to put in a UVC. So if you would take over holding it for too long, get that ready.
2 and 3 and breathe in. 1 and 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 2 and 3 and breathe in. 1
It looks to me like this baby weighs about 3 kilos. Would you agree?
That
sounds about right.
Okay. Circulator, we're going to need to drop some epinephrine. So we need epinephrine 1 to 10,000 concentration. We're going to need to drop 2 doses, one for the ET tube, that will be in a 3 milliliter syringe, which would drop 3 milliliters of epinephrine, 1 to 10,000. And then for the UVC, I want you to drop.
Although the endotracheal route is more accessible and faster than placing an umbilical line, the endotracheal absorption of epinephrine is variable. A dose of 0.3 to 1 milliliter per kilogram of 1 to 10,000 solution may be administered endotracheally if umbilical venous access has not yet been established. Deliver the medication directly into the tube opening rather than the adapter.
Should I reassess?
2 different routes and 2 different doses present a risk for medication error. Be certain that syringes are labeled and medication administered correctly. To insert an umbilical venous catheter, first place an umbilical tape around the base of the cord.
I hear good breath sounds on the right. I see good chest movement. Continue
Okay, we'll
with
continue
compressions.
compressions.
1 and 2 and 3 and 1 and 2 and 3 and.
Clean the cord with antiseptic solution and cut it with a scalpel 1 to 2 centimeters above the skin line.
Okay, I'm going to cut the cord and hold compressions for a moment.
Okay.
Okay, resume compressions.
1 and 2 and 3.